of our most recent findings and trying to make a hypothesis that this potentially, in some patients, may become a significant clinical pathology. So, as you all know, just to review, myocardial bridges is present in a large number of patients, especially at time of autopsy, 30 to 80% of the time. But a lot of times, angiographically, that could be silent. Most of the time, you may not appreciate it, but sometimes it can be very obvious. For example, in this particular angiogram, you see a large amount of systolic compression of the LAD in a long segment of the vessel. And about 40% of the patient with angina and normal coronary arteries, actually a myocardial bridge is present. So the question is whether this is just an incidental finding, not related to any of the symptoms. As you know, most of the myocardial bridge present in the LAD because of the presence of significant septals, and therefore sometimes the myocardial in teleology have muscle fibers over them. Generally, I think the teaching has been that this is benign, but at the same time, there's a fair number of case studies as well as reports that shows that it has been associated with, but not causatively, with myocardial ischemia, infarction, and VT and myocardial then sudden death. So you can click on that. So right coronary, just so that it shows you that not necessarily it only presents in the LAD, occasionally it can be present in the right coronary as well, especially in the septal branch with the milking of the vessel. It's the interesting part is that we would always tell our patient that these myocardial bridge obviously is present at birth, but the symptoms, if it is related to the myocardial bridge, typically do not happen before the third decade. The patient typically would develop exertional chest pain, although chest pain a lot of times may occur with stress, and over time these symptoms seem to get more persistent, and these symptoms especially becomes more acute in patients who are physically very active. For example, people who run marathons, people who do a lot of exertion seems to have more symptoms potentially related to myocardial bridge. Patients often have a lot of PVCs and also VT and syncope can be presenting symptoms as well. There have been reports of septal ischemia on nuclear perfusion scans and septal ischemia infarction as well on MRI and autopsy, showing that there's some relationship of the myocardial bridge potentially to septal ischemia as well as infarction causing scar and potentially leading to arrhythmia. So recently we've been studying, picking up a fair amount of this myocardial bridge by stress echocardiography. Essentially what we're finding is that you find a focal mid-septal buckling, which is pretty sensitive in picking up most of the myocardial bridge. Fine. So here, again, I'm not going to talk about echocardiography too much. Typically, you would see a septal bulging in during end-systole or early diastole, and usually this can be distinguished from LAD ischemia because the apex usually is spared, meaning that it's only the septum that has this buckling, and therefore it is clearly slightly different from, for example, LAD atherosclerosis and stenosis. The probably best method to detect myocardial bridge is from intravascular imaging. So here showing that echolucent has